I'd like to introduce you to our speaker today, Dr. Ashley Henneghan. Thank you, Dr. Henneghan, for joining us today.
Great. Thank you, Elaine. Thank you to the BCRC for having me today. I've had the pleasure of collaborating with BCRC since I think it was 2014 when I started to work with them. And the BCRC does so much for anyone affected by breast cancer in the Central Texas area. And now with this platform, we have reached to, who knows, globally, potentially. So I'm just so grateful for this opportunity to kick off this new series of, Ask the Expert. So a little bit more context for why I was asked to do this talk today. I am a nurse by training. I started my clinical practice here in Austin, Texas, and spent most of my clinical practice as a hospice and palliative care nurse. So I have always focused on symptom management and prioritizing people's quality of life as it is impacted by chronic diseases, including cancer. I got my PhD from UT Austin School of Nursing in 2017, and my focus was cancer-related cognitive impairments. I chose to focus on this area because of the devastating impact that cognitive changes can have in people's lives. And really, there was almost no research in this area when I started down this path. So I went to MD Anderson Cancer Center to do my postdoctoral training, and then was hired back at UT Austin in 2018 and have been on faculty there as an assistant professor in the School of Nursing. So now my research focus is aimed at treating and preventing cognitive and psychosocial outcomes in cancer survivors. And in terms of any disclaimers, I don't have any conflicts of interest to disclaim. I do want to say that I am not a cancer survivor, so everything that I'm talking about today is coming from the perspective of a clinician and a researcher. And some of the research I'll be talking about today has been funded by the National Institutes of Health and also the American Cancer Society. So thank you all for giving us questions when you registered. We had quite a few, and I'm hoping that I address most of them in this presentation. But specifically, I'll be talking about what are cancer-related cognitive changes, what causes them, and how can one prevent or improve these cognitive symptoms. So first, thanks to improvements in cancer screenings and diagnosis and treatments, we have a growing cancer survivor cohort in the United States and around the globe. There's almost 17 million cancer survivors as of 2020, 3.8 million breast cancer survivors, about 150,000 people living with metastatic breast cancer. And just for some context, about over half of all new breast cancer diagnoses are in women over the age of 65, and about 7% are under 50 years old. So something that I've heard in one of the first focus groups that I partook in is that you can be free of cancer-free, but not necessarily free of cancer. And what do I mean by that? So it's wonderful that people are surviving breast cancer treatments, but sometimes there are these late and long-term consequences, unintended consequences of treatment that appear. And they can be physical, psychological, and today we're talking about the cognitive. So what are cancer-related cognitive changes? Most people use the word chemobrain to talk about this topic, but as you'll see later in this presentation, chemotherapy is not the only culprit. So I like to call it cancer-related cognitive changes. And in practice and in research, we always talk about cognition in domains. So these are the cognitive domains that are most impacted by breast cancer treatment. We have executive functioning, which is our ability to multitask, to prioritize things, it's kind of this higher order cognitive functioning that, we as humans are good at. Verbal fluency, this issue of coming up with the right word, so word finding, the ability to speak fluently, memory, both short and long term, but there's different types of memory that are impacted by breast cancer treatment. Most often it's this idea of working memory, so the ability to kind of hold bits of information in your brain, such as like a telephone number, and then remember it a few minutes later. That's working memory. Attention, the ability to focus, the ability to tune out other distracting stimuli or things, and then focus on one thing at a time. Processing speed, the ability to take in information and then react. So the term chemo fog is kind of alluding to that, of this slowness to process and to react. And importantly, these in research that we've done and other research that have published, is these cognitive symptoms are some of the most distressing and disruptive and potentially disabling treatment effects. So it's a huge area of research. My area of research is focused on it because of these reasons. So what are some day-to-day examples? So I just talked about the cognitive domain specifically, and that sounds pretty researchy, but what do we really mean? And this is what I've heard in some of your questions and things that you wanted to hear more about. So slower to think through issues and respond. That's that issue of processing speed. Difficulty keeping track of what you're doing and multitasking. So that's that executive functioning. Feeling overwhelmed or bombarded with stimuli and or emotions. It's interesting, the part of the brain that's most impacted by cancer and cancer treatments is also the part of the brain that is responsible for our ability to regulate emotions. So those things kind of go hand in hand. Difficulty analyzing a situation, planning a course of action, and then carrying it out. So this that's an aspect of executive functioning too, of analyzing and coming up with a plan and then following the plan. You can also think of something complex like following a recipe, or preparing Thanksgiving meal that has multiple pieces to it. And then forgetting, fill in the blank, words, names, places, where are my keys, that sort of thing. That's usually short-term memory. So what are some statistics about this? What do we know? Approximately 30% of breast cancer patients exhibit some sort of cognitive deficit compared to healthy controls prior to treatment even starting. So this is, again, why we're turning away from calling this chemobrain, because cognitive symptoms can arise even before chemotherapy treatment. This number goes up during treatment. Up to 75% or more report having cognitive symptoms during their active treatment. And then for about 30% of survivors, their cognitive symptoms can last for months to years after treatment is over. And really, from person to person, the symptoms are so different. It can be very subtle or non-existent to very dramatic. They can be temporary or permanent. They can be stable or they could be progressive. So these trajectories of how it looks for individuals are so different, depending on what parts of the brain are impacted and what other things are going on. And I do want to make the point that the cognitive symptoms will get better for most people. Most of the spontaneous brain recovery happens in that first year after treatment is over, but for most people, they get better over time. Not everyone, but for most. So that is what we know so far in terms of the research that's been done following cohorts of cancer survivors and breast cancer survivors. One point I do want to make is that, I hear when I talk with support groups or work with research participants that there can be this shame and worry about, I'm not the same person anymore, and I feel really stupid, and this language comes out. And I want to make the point that intelligence, this concept of intelligence, is our individual intelligence is has so many aspects to it. You know, there's the wisdom that you've acquired over your entire life is not affected by cancer and cancer treatment. Your street smarts, your creativity, your somatic learning, these things are not. What we know is that it's more of an access issue. So being able to access those parts of your brain or connect between them, those are the issues. And fortunately, in the world of neuroscience, we are learning that we can regain cognitive functionings and that we can relearn things. So I want to make that point before going any further. So this is the question that I get the most whenever I tell people what I do in terms of my research. What causes cancer-related cognitive changes? And really, this is a complex issue. And after 30 years of research on this topic, we still don't know the exact causes, but we are learning quite a bit as to what makes people more at risk for developing this. So busy slide alert. So I'm going to walk you through this, but this is really illustrating how multifactorial individual cognition is. So a lot of the questions that I received too for this webinar had to do with what types of treatment might cause this. So the top peach colored boxes are all the different types of treatments. And this figure came from a 2020 review article that was published about cancer-related cognitive impairment, kind of update of the science. What do we know about it? So this is not necessarily specific to breast cancer, but over half of the research on cancer-related cognitive impairment is with breast cancer patients. So it generalizes to the breast cancer population. So chemotherapy, chemobrain, we know that this is definitely a factor here. Chemotherapy, we've learned from looking at animal studies that different agents are more permeable. They can get into the brain directly. There's also the indirect effects of chemotherapy by sparking an inflammatory response in the body. And inflammation is a good thing in the short term, but a bad thing in the long term. And chronic inflammation can also cross our blood-brain barriers and interfere with cognitive processes. So we said that it's not just chemotherapy that has been identified as a risk factor, but radiation. Definitely, if you have a brain met in the brain and you get radiation directly to your brain, that could interfere with your neural tissue and your cognitive functioning. But even radiation outside of the brain can spark an immune response and induce that inflammation and buildup of what we call oxidative stress. And those inflammatory markers and stress markers can interfere with our cognitive functioning as well. Immunotherapy. So there's very, very little research done. These are possible mechanisms that they're speculating based off of animal studies, but very little studies on immunotherapy or targeted therapy and the cognitive effects of that. It's surprising, but typically in clinical drug trials of these therapies, cognition isn't always monitored. There might be one question that asks people how their memory is or something like that is monitored, but it's not comprehensively studied. So there's potential for either of these therapies to interfere with the immune system and again have this systemic response and potentially lead in or cause neuroinflammation, inflammation in the brain, which affects cognitive abilities. We know a little bit more about, so endocrine therapy is hormonal therapy, this is especially relevant in breast cancer, since almost 70% of breast cancers are hormone receptor positive. So being on an anti-estrogen medication is part of most treatment plans. We know that estrogen is typically a antioxidant and promotes neuroplasticity. So people talk about menopause brain too, meaning that once those levels go down, there is some sort of impact on brain functioning. And then stem cell transplant, this is a whole different population of cancer patients who will go through intense treatments that can impact cognitive functioning as well. So those are all the treatments, and that's a lot going on there. But then there's all the patient-related factors. What makes one individual person more vulnerable to developing a cancer-related cognitive impairment? People's general health status. There's different comorbidities that that could also have cognitive effects, or there could be a synergistic effect if you have cancer in addition to type 2 diabetes or a cardiovascular issue. So people's general health status, nutrition and fluid balance. So if you're dehydrated or you don't have the right electrolytes when going through treatment, you could have cognitive side effects from that, or different nutrient deficiencies, such as the B vitamins. B vitamins are very important for brain functioning. Similarly, anemia. So we think B vitamins, we think iron and hemoglobin levels, vitamin D as well has been linked to cognitive functioning. So these factors are important to consider. And then there's been some studies identifying some genetic risk factors that make some people more susceptible to developing these cancer-related cognitive impairments. One of these genes is the ApoE gene, which is linked to Alzheimer's dementia. And then these other two have to do with neurotransmitters in the brain, and also basically just how the chemical makeup of the brain. What I added this, this one block to an already very busy figure, but my research is focused on the modifiable lifestyle factors that also make some people more at risk for cognitive impairment versus other. We found that stress and loneliness and sleep quality all are risk factors for having worse cognitive functioning. So another area of my research is look at the inflammatory mechanisms. So we've found that these are cytokines. These are a microscopic photograph of a cytokine, which is an inflammatory marker in our blood. I pointed out that different treatments can spark this. It's also an issue with ongoing stress. Stress can lead to chronic inflammation as well. We've found that specific cytokines are linked to specific cognitive functioning. So, the interleukin-4 was linked to, believe it was memory. So that these individual profiles of cytokines made some people at higher risk for having specific cognitive impairments. And whenever we look at cognitive impairment, we're doing it with standardized cognitive testing. And each test measures a different aspect of one of those domains that I talked about at the beginning. So we look at short and long-term memory, verbal fluency, attention, and executive functioning. So we did find links between higher levels of inflammation and cognitive performance. I also focus a lot. I mentioned that the part of the brain that is typically impacted by cancer and cancer treatment is also where emotional regulation happens. So cognitive symptoms very frequently co-occur with psychological distress or emotional factors like depressive symptoms or anxiety or stress. And at the beginning of when research on chemobrain started, it was actually an issue that clinicians would be like, oh, you're just depressed, or, oh, it's just fatigue, you're not having cognitive problems. It was kind of used as an excuse, and it kind of belittled or invalidated people's cognitive symptoms. So we spent many years trying to separate cognition from these emotional factors to prove that it was indeed its own issue or its own problem. And we've done that. It is a legitimate, real thing that happens. And now we're kind of circling back because these symptoms kind of present as a cluster. And rather than looking at them separately, might be more clinically relevant and appropriate to consider them together. There's also a stigma in our society when it comes to mental health and mental health problems. So I've heard some people say that they would rather have chemobrain than have, depression, but it's something that as clinicians and as researchers, we should consider. And this is one of our studies where this is just an illustration that all of these symptoms, this is daytime sleepiness, perceived cognitive impairment, stress, fatigue, sleep quality, anxiety, loneliness, and depression. In breast cancer survivors, they all clustered together. So they were presenting kind of all at once. And the good news is that we have some interventions, which I'll get to in just a few slides, that can address multiple symptoms at one time.
Dr. Henneghan?
Yes.
Can you explain what is executive functioning again, please?
Sure. Executive functioning is our ability to multitask, to prioritize, to work with multiple pieces of information at one time, to inhibit distraction and focus. So is that good? Does we need more examples?
I think that's good. Thank you.
You're welcome. So next, what can I do to improve my cognitive functioning? So the bad news is that we don't have a pill you can take. We don't have clinical guidelines in order to follow, but we do have a lot of research supporting different self-management strategies that can be tried. So I want to walk through them. And I mentioned this earlier, that we are in a very exciting time in the world of neuroscience, whereas not too long ago, like a decade or two, it was thought that once brain cells died, that was it, not getting them back. But now we've entered this whole frontier of neuroplasticity and how can I gain new neurons and new tracks between different areas of the brain. And it's this idea that our brains are constantly evolving for the rest of our lives. So how can we engage in neuroplasticity? So first, this is the NCCN. So there's NCCN guidelines for practitioners, but there's also guidelines for patients, and their survivorship guidelines for patients actually address cognitive dysfunction, which I was happy to see. So this is the website that you could access if you wanted to read this further. But first and foremost, let's see if there's any treatable contributing factors such as pain. Pain is also one of the late and long-term effects of breast cancer treatment that can interfere with our cognitive abilities. Sleep, we mentioned that earlier. If your sleep's not right, your brain functioning is not right. You can see that immediately with one bad night's sleep, or on the contrary, one very good night's sleep. Fatigue is very prevalent in breast cancer survivors, and depression. These are things that you can talk with your providers about if you're experiencing, and your cognitive symptoms could be a byproduct of these other treatable issues, and or a side effect of a medication or a supplement that you're on. So I encourage you to, if you're having these issues, to bring it up with your providers and to see if there's any treatable causes that can be addressed first. But if you go through those and you're still having issues, these are the evidence-based self-management strategies that I could suggest. So several systematic reviews and meta-analyses, which look at across studies to evaluate evidence in research, the most evidence supports the use of meditation and different forms of stress reduction. This has been the shows the largest effects on improving cognitive functioning. And I'll talk in the next couple of slides about one of our studies that we looked at the effects of a certain type of meditation, and I'll give you some more details on that if you're interested. Cognitive training or cognitive therapy. So when I talk about cognitive training, you could do this formally with a healthcare provider or independently through different types of brain games that are online. These are commercially available. The ones that come to mind are Lumosity, Brain HQ. I think they have apps for these now, but it's basically this brain health, brain training. Cognitive therapy is if you wanted to work with a therapist to go through different types of compensatory strategies. How can you do like workarounds for different symptoms that you're having? How do you cope with these? How do you find shortcuts to make your life, easier in that aspect? So cognitive training and cognitive therapy are similar but different, and they can be done formally under the care of a provider, or you can engage with some commercially available cognitive training. And I also want to say that when it comes to cognitive training, you can use a game that's designed for brain, different cognitive domains that we were talking about earlier. Or I also like to suggest that any learning of new things is a type of cognitive training. So and anything that engages multiple senses. So something like learning a new instrument, or engaging in a book club where you're reading new content but then discussing it. This using your brain, it's like physical therapy for your brain. So it doesn't have to be labeled cognitive training in order for it to be cognitive training, and hopefully that makes sense. Exercise. So I always like to say, all the courses that I took in neuroscience and neuropsychology, every professor I've had was an exercise fiend. It's known in that field that especially cardiovascular exercise sparks neuron growth. So and exercise in terms of other issues related to breast cancer treatment and potential recurrence is going to be beneficial for a lot of other symptoms like fatigue, and help reduce the odds of recurrence as well. So physical exercise is fantastic and highly recommended. Oops. So nutritional and dietary changes. This is a very new area of research. There's just been a couple papers that have been published and that I've seen that have started looking at using some supplements. And actually at UT Austin Dell Medical School in the Livestrong Cancer Institutes, there is a dietitian who specializes in cancer-related cognitive impairment. So if you live in the area and have access to her, it's Crystal Zuniga is her name. She specializes in this area. But really what they're finding is that antioxidants and fruit and vegetable intake, and then also some of the omega-3s, the good fatty acids, might be beneficial for cancer-related cognitive impairments. So something to consider if you don't get enough of those in your diet. Yoga, Qigong, and acupressure. So this is kind of that complementary and alternative medicine area where there is good evidence supporting that this improves quality of life, perceived cognitive impairments, and has like stress reducing effects as well. So it's kind of brings in some of that meditation and mindfulness, but also incorporates body movement with that. And acupressure is there's only been a couple of studies, and there's actually been some on acupuncture as well, but there is some evidence to support that with positive effects and minimal side effects. And a new area of research is using music-based interventions, and I'll talk more about that in the next couple slides, because I think our group was the first to evaluate the use of listening to classical music on a daily basis and it having positive effects on cognitive functioning. So I'll give you some more details on that. But
Dr. Henneghan?
Yes.
Um, Going back to the chart of treatment-related and patient-related factors, you spoke of when treatment is complete. We have a question: is there a difference between chemo infusions and chemo pills like Ibrance, more specific treatment? Can cognitive skills improve while on Ibrance or another similar treatment? And is this the same as targeted therapy?
Yes. I believe Ibrance is used for metastatic breast cancer. Is that correct?
Correct.
Yeah, so that would fall in the immuno or targeted therapy. I'm forgetting off the top of my head, forgive me, which one, but these are the areas where there's very, very little research done. But I will say that we're always able to do cognitively or brain healthy behaviors to kind of offset or try to balance out. So even if there's, if you think about it like scales, if you're undergoing targeted therapy currently, you can still kind of offset the scale by doing brain healthy behaviors too. So the evidence-based strategies I was talking about would, for the most part, I think, be available to anyone currently going through even chemotherapy. But the targeted therapy, there's been almost no studies done. And I was talking with Elaine about this a couple of weeks ago, is that I'm like, I need to start doing a study with metastatic breast cancer survivors who are on these treatments so that we can understand it more and see what treatment options might be available. But hopefully that answers. But unfortunately, there's just been essentially like no research done. Most of the time, metastatic breast cancer patients are excluded from these studies because the treatment plans are usually so different, and because of the potential for brain metastases. But we need research done, and perhaps I can work with the BCRC and we could do some more research in this area. Going back. Sorry, this is now one at a time. Sorry about that. Okay, so I mentioned some different types of healthcare providers, but I want to point out the types of providers that you could seek out if you're experiencing cognitive symptoms related to your cancer treatment. So obviously you're an oncologist, and your oncologist would likely refer you in one of these directions. So neuropsychologists they specialize in giving people the comprehensive cognitive assessment. So the types of tests that are specific to domains, you would go in and be evaluated and do a whole battery of these cognitive tests. And what they would be able to tell you is what parts of your cognition are being impacted or not. They usually will compare your scores to some sort of norm, like age and education adjusted norm. So to tell you what percentile you're in and where you are at. And more importantly, if you see them at one point in time, you can follow up, and then you can gauge if there's been change over time. So there are neuropsychologists in the Austin area. There's a cognitive clinic at the UT Dell Medical School. So these people or these specialists are in this part of Texas. So I'm happy to talk more about that too. My contact information, I don't think I mentioned this, is in the chat. I think Molly has put it in there. So I'm happy to talk more specifically if you'd like it. It's cognitive rehabilitation. So some of that cognitive training or therapy can be done in the context of cognitive rehabilitation. And the people who specialize in that are typically occupational therapists and speech therapists. A psychologist would be someone who could help with some of the cognitive behavioral therapy. And then I recommend integrative medicine practitioners. So if you're thinking you might have some nutritional deficiencies or might want to tackle things from a nutritional point of view, those are great experts. And then same with nutrition and dietitian. Those are people who might probably know about chemobrain, and nurses do as well. So if you're undergoing treatment, I've been part of the Oncology Nursing Society for a very long time, and there's a lot of education done on the side effects of treatment that nurses are trained in as well. So real quick, I was going to try to give a time check to see where I'm at. I'll just mention that we did a pilot study. These are the publications from it, where we evaluated both listening to classical music and also meditation after breast cancer in order to improve cognitive and psychosocial outcomes. And what the programs were, they both were 8 weeks long, and the meditation program involved a 12-minute daily meditation that, if you go to this website, it is available there. That we adapted this intervention from research that was done in the dementia space because of the positive outcomes that they had. So this type of meditation is called Kirtan Kriya, and it involves mudras, so finger movements, saying, it says chanting, but really it's just saying out loud certain sounds, and also visualizing, like there's a guided visualization component to it. That was daily for 8 weeks. And then the other group did listen to 12 minutes of classical music tracks. So, and they were from Bach, Beethoven, Mozart, and Tchaikovsky. Again, sitting quietly and focusing on the music for 12 minutes for 8 weeks. And this is kind of a busy research slide, but to illustrate that we saw improvements, this is on the left is the percent of people who improved in these areas across the bottom, which are, this is a measure, the FACT-COG is a measure of perceived cognitive impairment. This is a quality of life measure. Then this HVLT is a short-term memory. The HVLT delayed is a long-term memory test. This is a verbal fluency task. The trail A is an attention task, and then a trail B is an executive functioning task. So blue is music and orange is meditation. So we see almost all have improved in their perceived cognitive functioning, and these are just improvements across them. So we saw the least improvement in delayed memory, but improvements in the other tasks as well, from time 1 to time 2. So that was over those 8 weeks. We also saw improvements in some of the other symptoms. Our primary interest was cognitive functioning, and then we looked at some of these other symptoms that, if you remember, I said often co-occur and present with cognitive symptoms. So perceived stress, anxiety, depressive symptoms, fatigue, pain, and this, what I find important, the sense of self-efficacy of being able to manage cognitive symptoms related to cancer treatment. So the music group, almost over half improved for the most part on all of these other outcomes. So we're really excited about this. We're putting in a grant to study this further in a larger sample, but we're pretty excited because we were the first people, to our knowledge, to study the effects of music on the brain. That's an area of active research right now. So work and home life, people's cognitive abilities impact every single aspect of their lives. And I heard some comments in the questions about how do I talk to my loved ones about this, and how do I explain this to other people? And also, this is impacting my work and my work performance. So how do I talk about it? And I think step one is really normalizing that this is a real thing. I know when I started working in this area that so many patients were told that this isn't real, that you're just depressed, you're just fatigued, but it's a very real and legitimate thing. There's not a ton of research, so sometimes clinicians will say, well, we don't know anything about that, but we do. We know a lot about this, and we know that is in fact a real problem. So I think normalizing and then explaining that it usually gets better for most people. And to try to manage expectations is a great place to start. But that's where I would start in terms of friends and family. And then when it comes to work, I want to point you to this resource. This is a fantastic resource because when we talk about work-related issues and how to disclose and what to disclose, we're getting into legal, the human resources and legal related issues. And I am not credentialed to give legal advice. But it's the cancerandcareers.org. And if you go to that website, there's all sorts of resources. And I think you can actually work with one of their career coaches who is trained specifically in cancer-related return to work issues. So there's if you look to the left-hand side, it's legal and financial, sharing the news, all of these things going back to work, handling discrimination, and then tips for getting organized, like coping with different types of symptoms, including cognitive, while returning to work and all of that. So I highly recommend checking this out. I also, before I wrap up and take some more questions, I encourage you to connect with us if you're interested in doing any research. We have studies going on right now. I work with some other researchers at UT School of Nursing, and we have the Cancer Neuroscience Laboratory, and our studies are typically listed on this web page, and there's usually direct links for trying to get enrolled. And then in 2022, hopefully we'll be having at least 2 more studies rolling out that we'll be recruiting for. So if you would like to participate, feel free to either monitor that website, or you could email me and I can include you on our email list. Whenever we have a new study, I send it out to people who wanted to know about our studies. And I will also be happy to give you a PDF of this presentation as well. So with that, I would love to take some more questions. I see there's chats, but I haven't been able to look at that until right now. So
yes, we have several questions. So one of the questions I want to ask first are, what are some misconceptions about chemobrain?
Well, for misconceptions, I would say that it's just caused by chemo. So that is probably the biggest misconception about chemobrain. And that other treatments can cause it, that cancer itself could be a contributing factor. So it's not just chemotherapy. That's the biggest misconception. And also that chemobrain is just people being depressed or fatigued. I've alluded to that several times in this presentation, but I want to reiterate it that it is not just that. It has its own underlying biological manifestation, and it's very, very real.
And so I'm assuming this is what she meant, that is chemobrain related to cognitive reserve.
Yes. So I didn't talk about cognitive reserve. Cognitive reserve is basically, I guess I alluded to it when I was talking about the wisdom acquired over a lifetime. So if you think about cognition as like a bank, there's a lot of things you can do to build up the bank, and how like your life experience and education all have to do with the reserves that you have available. So it's thought that people who have a lower cognitive reserve are more impacted by cancer and cancer treatments because they have less to pull from. So if you have a more robust cognitive reserve, or if you do things now to increase your cognitive bank, then it can help offset it. So yes, they are related to each other.
Great. There is another question.
Okay.
Is there a correlation between age and cancer-related cognitive impairments?
That is a great question. So in general, age, there's age-related cognitive decline that happens to all people. And the slope of the decline is individual, and it sometimes becomes pathologic in cases of dementia and things like that. So everyone's at a certain age, which is a surprisingly young age for the record. It's like around in your late 20s or early 30s, you start this very slow, steady decline. So there's a relationship because you're aging while going through cancer treatment. I will say that younger breast cancer survivors tends to be a risk factor for having worse cancer-related cognitive impairment. We used to think that older age was the risk factor, but we're actually seeing a high degree of problems in younger patients too. So the relationship between cancer-related cognitive impairment and age is complex. Really, it's the young and the old that seem to be the most vulnerable.
There's a couple of comments in the chat box. So someone said, as someone with metastatic breast cancer, I would like to see more studies done with MBC and cognitive changes.
Me too. And I think I'm going to do one after giving this talk. We need more.
We do have some, right. We do have someone who would like you to just to do a quick summary of the immunoresponse for treatment causes inflammation. And she's questioning of neurons, which causes side effects. And she's asking if that's correct.
Okay, let's see. I'm trying to find where that is so I can read that. It's in the comments or the Q&A?
It's in the chat box.
Okay. Immunoresponse to treatment causes inflammation. Okay, so the targeted immunotherapy treatments are interacting with your body's immune system to try to stop the cancer growth. So by interacting with your immune system, it doesn't just affect the one part of your body. It's a type of systemic treatment that is going to impact other parts of your immune system. Our inflammatory system is part of the immune system. So it's an unintended consequence that it can disrupt the system. And when we have inflammation in our bodies over a long period of time, it causes the barrier that's between our bodies and our brain. It's part of everyone has one of these. It's called a blood-brain barrier. It's supposed to keep out bad things from the brain. It's part of evolution. We protect our brains because it keeps us going and keeps us alive. But when there's chronic inflammation, it causes the very tight junctions in the blood-brain barrier to become weaker and start letting things pass into the brain that shouldn't necessarily be there. So that can then cause what's called neuroinflammation, where there's more inflammation in the brain. So it's complex in terms of how that happens. And right now that's theorized and only really been tested in animal models. So that's what we think is going on. Hopefully that helps.
I want to, something you mentioned before, and we're always talking about supplements and, vitamins to go along with nutrition and exercise, but you mentioned vitamin D. So can you speak on vitamin D and the brain, and should someone be, adding that into their regimen or talking to their doctor about it?
Yeah, vitamin D is now seen as a huge factor in a ton of chronic diseases. And I mean, I think it's like almost everyone's deficient in vitamin D, most likely. So most practitioners, like just primary care providers, are monitoring vitamin D levels and then supplementing if you're deficient, because it can just have a very wide range of positive effects on your body and your biology. So I would recommend anyone, during your annual workup, or if you're seeing your physician more frequently and you haven't had a vitamin D level drawn, to have one drawn. It would only benefit you to have appropriate levels of vitamin D for cognitive functioning, but also your other biological functioning.
if you're okay, we still have a couple more questions. There's some great questions coming in.
Yeah.
This person said she started taking ADHD medication about 6 months.
Okay.
She was diagnosed. So between not having quite nailed down that before treatment and the additional cognitive decline, my brain feels like it's taking a beating and still haven't quite figured out the silver bullet in medication wise. So the question is, do the folks at the cognitive lab ever work with patients like this?
So patients that have ADHD.
Yes, I believe she means ADHD and taking medication.
Yeah. So I think I said that there isn't, I wish there was a silver magic bullet for this in terms of medication, but really there have been some pharmaceutical drugs evaluated in clinical trials to see if they would improve chemobrain, and they haven't been very effective. And they've studied the stimulants, which are usually used for the treatment of ADHD or ADD. And because of the potential side effects of those drugs, they have not been recommended as a general guideline. As individuals who have other comorbidity situations going on, such as ADD, that's might be totally relevant to try something like that. Or if you're having fatigue, or if it's not contraindicated for you to be on a stimulant, that's something that your provider can try. So on an individual level, that type of medication might be very appropriate to try. It might be very effective. But in terms of our team looking at that interaction potentially between someone who has a pre-existing cognitive related issue, we typically, it's part of the research designed to exclude people who already have those issues, because we're trying to understand the impact of the cancer and the cancer treatments outside of the context. So that's one of the downfalls of research, of trying to make things as, controlled as possible. But it would probably, I can understand that it's challenging if you're having kind of a double whammy of already having a pre-existing issue that's now potentially being hit. So I think that hopefully your provider is on board with it and help trying different types. There's all different types of stimulants as well. On the topic of medication, I will go on somewhat of a tangent and say that they've also evaluated some dementia related medications, and they also have not been effective at all. And actually a couple of the trials, they discontinued the trial because of some negative side effects. So pharmaceutical management of cancer related cognitive impairment is not, it's not very developed, and there hasn't been good research done on that area.
So along that same lines, the next question was, I believe chemobrain are anyone with chemobrain at a higher risk of Alzheimer's dementia potentially later on?
Yeah, that's a great question. So we've only been able to look at that really using simulated data, which gives us some sort of insight, and that's looking at like a kind of biobank of brain related data. So we've seen that there might be some increased risk if there's a hypothesized mechanism that cancer related cognitive changes are a function of cancer and cancer treatments kind of accelerating biological age. So that, there's all these different things in our daily lives that can either like turn up aging or turn down aging, and going through all these different types of very intense biologically speaking treatments can kind of amplify aging. So it's possible, and this is all possible, this hasn't been studied because we don't have cohorts that we've been following for 20 years. Unfortunately, this is a newer area of research, and maybe we're following them 5 years. We just got funded a few years ago to continue following a cohort that we followed for another 5 to 10 years, so we can start to answer some of these questions. But what we know is that it may it may increase one's risk to develop that, but it's not a cause and effect type. We do not have that type of research done yet. It's possible if it does accelerate biological aging. And the thinking there is that that someone may have already had a predisposition for Alzheimer's or dementia that got just kind of sped up by going through the cancer and cancer treatment. But there's not enough research done for me to say definitively one way or another.
Thank you to Dr. Henneghan again for a wonderful presentation. And I appreciate you spending time with us today. And the recording of this webinar will be uploaded to our YouTube channel as soon as we get it edited. And again, Dr. Henneghan's contact information is in the chat box if you have further questions regarding anything that she didn't get to today. And with that, I want to say thank you for joining us today, and I wish you a happy holiday. Goodbye, everyone.
Hey, everyone. Thanks for coming.